right. Well, welcome back to the second half of the lecture on when and when not to use PET-CT. This half of the lecture is going to focus on applications of FDG outside of cancer, and then also on some non-FDG radio tracers that are either relatively new or newly FDA approved. So starting with FDG. So I guess you could say the strength of FDG is that it's useful in so many things, but of course weakness can also be that it's useful in so many things. So there does tend to be a non-specificity to FDG uptake. And here we're going to examine some of the uses that we can put that non-specificity to outside of cancer. One of those is imaging dementia. So although we still think of dementias by and large as a clinical or postmortem diagnosis, there are many patients that present with apparent dementias that have a lot of symptom overlap, so it may not be obvious what kind of dementia they have, and that can be useful in helping to narrow that down. We'll say that we generally think that FDG-PET loss of signal or hypometabolism in the brain is indicative of neuronal cell death. So when we're imaging dementia with FDG, and if there are findings suggestive of dementia, it is usually at a point where we should consider it to be sort of a truly irreversible disease. Here are some of the patterns that we can see with FDG-PET in dementia. So Alzheimer's disease is far and away the most common dementia that we may encounter, and it typically has hypometabolism primarily within the parietal and temporal lobes. I should mention these images from the literature are surface heat maps of the brain, so areas that have sort of hotter colors, so the oranges and reds, those are most hypometabolic relative to a database of normal individuals with normal brain metabolism. So black and blue are sort of good areas of the brain, preserved areas of the brain, and green is starting to get to be abnormal, and then yellow, orange, and red are distinctly abnormal. Alzheimer's disease, parieto-temporal distribution, dementia with Lewy bodies is sort of unique in involving the occipital lobe, and often those patients do have visual hallucinations. And then with frontotemporal dementia, as the name would imply, there can be frontal predominance, temporal predominance, or a combination of the two. And again, those are areas of hypometabolism relative to normal brain. If you work in a hospital-based PET practice, there will often be lots of requests for looking for infections, looking for fever of unknown origin. I would say that for the most part, there's very little in the way of proven utility of FDG-PET in identifying infection. This is evolving over time, and there are a couple of not unreasonable indications. So in patients that may be relatively younger, don't have a lot of degenerative change in the spine, don't have a lot of inflammatory stuff going on in the spine at baseline, if they cannot undergo an MRI, FDG-PET, if it's normal and doesn't show any abnormal uptake in the spine, essentially rules out osteomyelitis discitis. Problem is, if there is uptake in the spine, it doesn't necessarily have to be osteomyelitis discitis. It can be degenerative change or inflammatory arthropathies. So one has to interpret uptake in the spine with caution, but again, a normal spine with no uptake does sort of rule out the diagnosis of osteomyelitis discitis. There's also some evolving indications that FDG-PET may be valuable for cardiac device infections, but again, somewhat preliminary and kind of evolving indications. And most other reasons that people may seek out PET for infection imaging, such as along grafts or articular prosthetics or in diabetic feet, those really, FDG-PET is just too nonspecific, and all of those things can have normal sort of inflammation associated with them or normal persistent uptake. So for all of those indications, I would say there's very little value for in using FDG-PET. Things do change a little bit if you look at fever of unknown origin. So because fever of unknown origin doesn't have to be infection, it can be sterile inflammation such as vasculitis, or sometimes cancers like lymphoma can present with fever of unknown origin. For those reasons, at least if you look at its sensitivity and sort of the diagnostic yield of the imaging test, FDG-PET is actually a great test for that indication. It will find potentially all of those things if they're present. So I think for sort of whole body imaging for fever of unknown origin in a patient that doesn't have a confirmed infection, FDG-PET's actually a great way to go. There won't necessarily be easy to have, say, insurance pay for that indication, but there is literature supporting it, and it can be the right thing to do for patients. There's a couple of different cardiac reasons that we use FDG-PET. So one of those is for cardiac viability. So in a patient that has a known perfusion defect that is present at rest imaging, the differential for that defect is either transmural scarring or hibernating myocardium. And we can actually tell the difference between that with FDG. Transmural scar will not take up FDG, whereas hibernating myocardium will. Patients have to be properly prepared for this. It can be a complex protocol to get right, so it is fairly intensive on the technologist and on the interpreting physician to go through all the steps to make sure everything is right, make sure that the patient gets into a good hyperglycemic and hyperinsulinemic state to drive FDG into the hibernating myocardium. But if done correctly, what this does is it allows us to identify those patients that would benefit from revascularization. So if you look at patients that have a fixed perfusion defect with no viability, so they don't have FDG uptake in their fixed defect, if you take those patients to revascularization, they wind up not doing any better and maybe marginally worse than if the patients aren't taken to revascularization and are just medically managed. So they have sort of the upfront morbidity of the invasive procedure for revascularization without any actual benefit in terms of improved ejection fraction or anything along those lines. Whereas if you take patients that do have viability, so there is FDG uptake in the area of lack of perfusion, those patients will typically do much better after revascularization than if they're not revascularized. So this really is a great way to risk stratify patients, and is probably an overall underutilized methodology before patients undergo revascularization. The other big cardiac indication for FDG is to look for sarcoid or myocardial inflammation. And clinical presentations of sarcoid can include things like arrhythmias with syncope or congestive heart failure in a young patient that doesn't have other evidence of early coronary artery disease. Practices will vary a lot in terms of how much sarcoid they see. Our clinical practice happens to see a lot of sarcoid in Baltimore. It's sort of a very, very endemic in our patient population. But again, this may be a fairly uncommon disease in some clinical practices. Here we're going to do sort of exactly the opposite in terms of patient preparation as we would with viability. And we're going to put the patients on an all-fat diet for at least 24 hours before the start of the scan. We don't want them to really have any carbohydrates on board. In diabetic patients, this can be a challenging protocol to pull off. But if we do it right, by depriving the myocardium of glucose, it switches over to a fatty acid-based metabolism. And then when we give the patients FDG, because the myocardium isn't using glucose, it doesn't take up that FDG, except in areas where there's active inflammation. So sarcoid granulomas will then take up FDG, and there won't be FDG in the rest of the myocardium. And we can identify the evidence of the myocardial inflammation in patients. And this is also a great way to follow patients that are then put on immune suppressive therapy to treat their sarcoid, whether that's steroids or even harsher immunosuppressants. So we can follow very effectively follow therapy and determine if the patients have sort of a breakthrough and need additional immunosuppressive therapy. All right, so that kind of covers everything that we'll talk about in regards to FDG. Now looking beyond FDG, so these are going to be additional FDA-approved radio tracers for indications that FDG may not be any good for and that we've needed new radio tracers for. And first, we're going to start off in prostate cancer. So as we said in the first part of the lecture, a role of FDG in prostate cancer is very limited, but we have a couple of new FDA-approved or relatively new FDA-approved agents for prostate cancer. And they're specifically approved by the FDA for use in biochemical failure. So these are patients that have either persistence of an elevated PSA after attempted curative therapy, or they achieved a PSA nadir or an undetectable PSA, and now their PSA is rising again. And the two agents that are FDA approved are C11 choline and then an F18 labeled agent known as FACBC or flucyclovine or Aximin. We'll start out with C11 choline, which has been around for a number of years now and has always been somewhat limited in the sense that C11 has about a 20-minute half-life. So this really needs to be made on-site at a cyclotron facility with PET radiochemistry available. And that really limits the ability to sort of bring this out to the population in a broader sense. So this has really been the purview of a couple of academic centers that have used this. And it's not a bad radio tracer by any means, although the sensitivity for detecting a potential site of disease is relatively low at low PSA levels. So when you look at PSAs less than 1, it's generally going to be maybe a third of patients that'll have a finding. Some studies say it's even lower than that. And as you go to higher PSAs, you are more likely to find a putative site of disease. But you also get outside of a window where the patient may benefit from, say, salvage radiation therapy to the pelvis, and they may develop over metastatic disease at those higher PSAs. So the clinical question is really at low PSA values, and that's sort of another reason that choline has never caught on, is the thought is that it just isn't sensitive enough at low PSA to really effectively guide therapy in patients. Flucyclovine or Aximin is sort of the new kid on the block. This was approved in 2016 for biochemical failure in prostate cancer patients. And it's an artificial amino acid PET radio tracer. Uptake correlates with amino acid transporter expression on prostate cancer cells. And for whatever reason, prostate cancer really does have a lot of these amino acid transporters, and this agent will localize in prostate cancer pretty well. I think if you look at the data with Aximin, it does do better than choline at every sort of gradation of increasing PSA. You'll notice the numbers here relative to a couple of slides ago would suggest that this study found choline to be less sensitive than the other study. That is true. I will point out that the group that published this data, they were using generally less than the FDA-approved amount of C11 choline to generate this data. So they may have lost a little bit of sensitivity by using lower injected quantities. Nonetheless, it does appear, again, that Aximin is superior in terms of detection efficiency relative to C11 choline. Because it's F18 labeled and F18 has about a 2-hour half-life, it can be centrally manufactured and then distributed to PET centers all over a given region. So this, I would say, at least most centers in the U.S., is now the preferred method of imaging biochemical recurrence prostate cancer patients with PET. It will likely remain that for a little while longer. There is something in the pipeline, a number of agents that target something called prostate-specific membrane antigen, or PSMA. PSMA has been widely accepted throughout much of Europe and parts of Asia and Australia as the new clinical standard for imaging prostate cancer. And so I expect that once one or more PSMA agents are approved in the U.S., those will really swamp the market in terms of imaging prostate cancer. At least that's my personal opinion, but I think that's shared by most people that do prostate cancer molecular imaging. All right, so leaving the prostate cancer realm, we'll just briefly mention amyloid agents for dementia imaging. As we said earlier, FDG is actually pretty good for dementia imaging, but there are a number of FDA-approved agents for imaging amyloid deposition, specifically in Alzheimer's disease patients. So Alzheimer's disease patients, they develop these amyloid plaques, and those tend to be in the gray matter of the brain. Normally, there wouldn't be uptake of these agents in the brain gray matter. There is uptake in the white matter, but when you have a patient with amyloid plaques, you start to see deposition in the gray matter as well. The limitations of this are that it really only works for Alzheimer's disease, so other dementias don't typically show any abnormality with this agent. So here in this image from the literature, you can see there's a healthy control on the left, Alzheimer's disease patient in the middle, and a frontotemporal dementia patient on the right. The healthy control of the frontotemporal dementia images look exactly the same. So again, we're sort of limited to just looking at Alzheimer's disease. And then somewhere around 20% of patients that actually have an abnormal amyloid scan, so they have evidence of amyloid plaque deposition, will not in their lifetimes go on to develop Alzheimer's disease. So there is sort of at least a psychological burden implied by that if you scanned everybody with these agents, you would identify a lot of patients that aren't going to develop Alzheimer's disease. So whether you consider that sort of a false positive, or those may be patients that just sort of die of another cause before they ever develop Alzheimer's disease, is hard to say. But those are the limitations to this. I would say that these haven't gained a great deal of clinical traction as yet because of those limitations. But there is a large ongoing, there's actually a couple of studies now looking at sort of good ways to potentially utilize these agents. One of those large studies is the IDEAS study. These should tell us quite a lot about how to use these. There's already some preliminary data that's coming out. So IDEAS, there's a paper where they found that clinical management was impacted in a large number of patients based on the results of the amyloid scan. Of course, dementias tend to have universally bad outcomes, so whether those changes in management will manifest as sort of more meaningful clinical endpoints, I think is tough to say. But again, we will have data that'll be pretty definitive from large multi-center trials as to how to use these agents. And then I do want to talk about gallium dotatate, and I'll spend a few slides on this. This was also FDA approved in 2016, and I would say at this point it has pretty much replaced indium-111 penetratide or Octreoscan in clinical practice for imaging somatostatin receptor expressing tumors. Octreoscan was, for a long time, clinical standard in the U.S. It was actually replaced probably a couple of decades ago in much of Europe with gallium dotatate and a couple of other agents that are essentially equivocal. So gallium dotatoc is also approved now in the United States by the FDA. But what these agents do is they have very high tumor to background ratios and excellent ability to identify sites of disease in a number of somatostatin receptor expressing tumors, and that includes pancreatic neuroendocrine tumors, many malignant pheochromocytomas and paragangliomas, as well as medullary thyroid cancer. And the somatostatin receptors are a family of cell surface G protein coupled receptors. Both Octreoscan and dotatate primarily bind to somatostatin receptor subtype 2. That's a little bit of trivia. Doesn't really matter in terms of what we see on the scan, but luckily somatostatin receptor subtype 2 is actually very commonly expressed on the diseases on the previous slide. And if we compare kind of planar imaging with Octreoscan versus a dotatate PET scan, really we just see so much more on the dotatate PET scan, and it's really going to allow us to see tumors with very high contrast and very high tumor to background ratios. Here's an example of what might be a somewhat subtle pancreatic neuroendocrine tumor. There was a lot of cystic degeneration within this tumor, so the arterial enhancement wasn't necessarily that great. But as you can see on the dotatate PET in the right-hand image, this thing is just light bulb bright. This also applies to metastatic disease, so here's just a few examples: lung metastasis, some liver mets, and a peritoneal implant. You can see all of those light up with very, very high tumor to background. This is a patient with a somatostatin receptor expressing malignant paraganglioma. And as you can see in the images on the right, I mean, they're very, very subtle bone lesion. I don't think I would ever call that on CT alone, but you can see that there's a very intense radiotracer uptake at that site. And we're really able to see very, very small sites of disease, very subtle sites of disease. Because the tumor to background is so high and the contrast ratio is so high, we really are able to pick out even very small tumors with this agent. I know I poo-pooed the idea of sort of clinical impact or management decision-making when it came to the amyloid imaging agents, but I think when you're dealing with an oncology radiotracer where your endpoints are maybe a little bit more immediate and there can be much bigger changes in terms of what the impact of that patient management is, I think it is a relevant thing to discuss when we talk about dotatate. So it's actually, there are studies that say that a majority of patients will have a planned treatment change when they are imaged with dotatate versus conventional imaging with, say, anatomic imaging or even Octria scan. And major changes in therapy include finding occult metastatic disease in a patient that may be going to surgery for what was thought to be a clinically localized disease. So these really can have, this agent really can have major impact in terms of how patients are managed. And what it's really doing is setting a bit of the stage for what's kind of becoming a revolution in nuclear medicine and what will become a perpetually changing and maybe even a radically changing thing for all of radiology in terms of how we have to think about how we practice medicine, and changing from just diagnosticians to diagnosticians that also administer therapies. So we've done this forever with thyroid cancer, where we image with I-123 and then we treat with I-131. But what gallium dotatate has opened up is treating patients with lutetium-177 labeled dotatate, or Lutathera, which is also now FDA approved in the United States. And this is really a therapy that is now available to patients that really didn't have a lot of good therapeutic options before. These metastatic neuroendocrine tumors oftentimes don't respond well to chemotherapies. They're oftentimes external beam radio resistant, but they respond often very well to Lutathera. And so there's meta-analytic level data about this. There's a very nice prospective New England Journal paper on the NETTER-1 trial from a couple of years ago. And so we absolutely know that patients benefit from this therapy. We can select them with a PET scan that shows that they have uptake in their tumors, and then we can treat them, we can administer therapy effectively. Of course, it will be incumbent upon radiologists and nuclear medicine practitioners who feel comfortable administering these therapies to really be patient-facing and to make sure that those patients are coming to us and receiving therapy from folks that really take this seriously and are experts in this. And if we give this up, then other oncology specialists will sort of take this from us. So I think it is important for us to make sure that we're the folks that are doing this. With that, I will thank you for your attention.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website CTisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.